Started 2 minutes.
Next page, ma'am. First page.
Started 10 minutes.
Ma'am.
Yes, started.
Hi, I'm Muthulakshmi, one of the exam candidates today, and read the instructions ready for the structured discussion.
Okay. So what will be your immediate management after entering into this patient's room?
So this is an obstetric emergency, severe postpartum hemorrhage with a background 30-year-old primary just delivered and placenta also delivered. So here immediately I will activate the CRMA protocol. Here communication, resuscitation, monitoring and investigations, arresting the cause will happen simultaneously. So communication to the patient about what is happening and communication uh, to the call for help. Uh, like I'll call my consultant, I'll call the senior labor ward coordinator and alert the blood bank and the hematologist, alert the OT, and also alert the consultant who's on call, and also I'll call consultant who's nearby. And next, check the ABC approach, airway, breathing, circulation, connecting to high flow oxygen with 10 to 15 liters per minute by face mask, and securing two wide bore cannulas of 14 gauge and sending investigations like complete blood count, liver function, renal function, coagulation, blood fog grouping, and at least 4 units cross matching now. And put in Foley's catheter for input output charting and continuous monitoring of vitals, and patient has to be kept warm and flat. And if also needed a continuous monitoring of vitals with a monitor with a pulse oximeter or the central line needed, early access will be better. And next I'll same way I'll start with the rubbing of the fundus to check for the tone. And the same way with the IV line, the medical management will be started. So starting with the, before starting the medical management, we'll rule out allergies, we'll rule out contraindications for any drugs. So first starting with the oxytocin 5 units slow IV infusion, then followed by ergometrin 0.5 milligram IV or IM if there is no contraindication like hypertension and heart disease. And next we'll start oxytocin infusion 40 units in 500 ml normal saline with 125 ml per hour. Then next drug will give you a prostaglandin F2 alpha 250 microgram intramuscular. There is no contraindication asthma, and maximum we can give 8 doses to 15 minutes interval. And misoprostol 800 microgram sublingual, and can also give tranexamic acid 1 gram IVBD. So with the rubbing of the uterine fundus and the medical management, if not settled, then we'll go for a tamponade measures. So first, a patient will be shifted to OT, and patient will be explained about this, and the consent will be taken. High risk consent will be taken, explaining all the possible procedures we'll do, including with obstetric hysterectomy. First start with a Bakri balloon tamponade. Then if not settled, we can go for a examination under anesthesia to check for any tears, and also compression sutures starting with the brace sutures. Then can consider stepwise uterine artery ligation for unilateral followed by bilateral, low ligation followed by high ligation, unilateral, bilateral, and ligation of utero-ovarian anastomosis, internal iliac artery ligation if the experts are available, and we can consider uterine artery embolization if the interventional radiology experts are available and nearby, and the last resort is an obstetric hysterectomy with the opinion of the second consultant. And
Okay.
we'll follow the WHO safety checklist during the procedure.
Okay. What are the 4 T's of PPH?
So the commonest will be the tone. Next is trauma, then tissues, retained placental tissues, then thrombin.
Okay. And how you will be managing each case depending upon the means if it is tissue, thrombin, or trauma tonicity. Tonicity you had mentioned.
Yes.
How you are going to manage other 3?
So it is trauma. So we need to do examination under anesthesia, uh, following a WHO safety checklist. So to look for the tears, whether it is a vaginal laceration, cervical tear, or if any tear is extending into the broad ligament or into the cervix or a uterus. So
Okay.
accordingly, we need to repair those tears with the help of the consultant.
Okay. What it
And if
is?
it is a retained tissue, so
Yes.
most commonly it is a placenta. So we need to do a placenta manual removal of the placenta under anesthesia by following WHO safety checklist. So before that, we need to check if there is any adherence. So we'll create a plane between the placenta and the uterus. We'll introduce our dominant hand in a sweeping manner. We'll separate the placenta. So complications will anticipate is a postpartum hemorrhage and postoperative later infections.
What you will be doing for infection?
We'll be giving a broad spectrum IV antibiotics after ruling out allergy in the postoperatively.
Okay. So now you had all this investigation of these patients. Okay. So the investigation is something like this. WBC, hemoglobin 65 gram, 6 gram percent, platelets 78,000, fibrinogen 1, and APTT is 1.5 times. What will be your
So
further
here
action?
the target blood levels achieved hemoglobin has to be more than or equal to 8 gram per deciliter, and the total count is 12,000 is normal, and platelet has to be more than 75,000, and fibrinogen level has to be more than 2 gram per liter, and APTT has to be less than 1.5 times normal. So here we need to give a cryoprecipitate and fresh frozen plasma 12 to 15 ml per hour. Depend on the hemodynamic status, it can be increased more than 15 ml per hour also. And here a blood products, pack cell transfusion needs to be given minimum 2 because hemoglobin is 6.5 gram per deciliter.
Okay. Okay. What are the post-surgical management regarding these patients? You had completed the surgery also. So what will be the post-surgical management document
The
means
clinical
regarding
part
this?
and clinical part and clinical governance part. Clinical part will be detailed documentation of the operative notes and giving IV fluids, analgesics, antibiotics, and thromboprophylaxis after discussing with the hematologist. And the patient will be shifted to HTU for continuous monitoring of the vitals in a MEOS chart and input-output charting. And once the patient is stable, so we'll explain the situation to the patient, and this patient is fine, started moving and started taking fluids, we can plan for a discharge. So the care plan will be communicated to the GP and the community midwife, and we'll also give a follow up in 1 to 2 weeks time. In between, if there is any red flags like fever, foul smelling discharge, or any discharge from the wound, so she has to report immediately. Clinical governance part, debriefing the team, debriefing the patient, and debriefing the family, documentation, date entry, and inform the risk management team. And we can also consider reflective practice for this.
Okay. Anything else you wanted to add to any of these questions? Well done. Well in time.
Thrombin deficiency we need to correct with blood products depending on the hemodynamic status and the laboratory values.
Okay. What about baby? Baby.
Once post operatively, once she is okay, so we can encourage her in the breastfeeding. And here we'll tell about her the whether that is a total hysterectomy or a subtotal hysterectomy. And the subtotal hysterectomy, smears and cyclical bleeding can happen. And here the ovaries will be retained, so she will have a estrogens. So she
Yeah.
will not have any symptoms because of estrogen deficiency.
Okay. Anything else you wanted to add to any of this point?
I didn't mention like fluids, how much I should give. 2 liters of crystalloid and 1.5 liters of colloid initially
Yes.
till the blood arrives.
Till the blood arrived. That was the point which you had missed out.
Mm,
Even I had mentioned that only.
mm.
Uh, okay. Only two, 3 points what I had wanted to tell you. Whenever, means once the patient has been stabilized, okay, the next thing you have to ask what is a brief history regarding a labor, and you need to mention about 4 T's. Okay, here I will keep in mind, although most common reason for a PPH in a primary gravida is atonicity, but also would like to keep in my mind rest of the 3 T's.
Please.
That is, yeah, yeah. So at least the examiner is aware, okay, you are not only atonicity, you are keeping in mind alternatives options, alternative cause of PPH also. So that is one thing you have to mention. And that's the reason you wanted to know in detail about the mode of delivery and whether there are any risk factor. Okay. Mode of delivery and labor progress, labor fat. Okay. Accessing case detail. These points are very important in this case. Information gathering is here actually, dear. In
Okay.
this domain, information gathering is here, no? So
Okay.
that will be, yeah, that will be in the information gathering. That point will come into information gathering. Yes, you missed out on fluid. Later you realized, you mentioned that. Examination under anesthesia will be the first thing, and then only you will go ahead with the surgical line of management. That is
Yes.
balloon. Yeah. So you mentioned balloon procedure first, and
Definitely.
then you examination under anesthesia. No, and at the end, whenever this kind of station comes up, we tend to forget about baby. Do not forget about
Yes.
baby. Yeah, so once the patient will be stable, we can encourage breastfeeding, encourage mobilization, and baby will be also seen by baby doctor or a neonatologist, not baby doctor, neonatologist, since it's a structure discussion. Okay, so not to forget about baby, that these are
Yes.
very important points. Okay, rest of the task done wonderfully, including CVP line also. Means even I had missed, I was about to miss out on CVP line. Last moment I added this point in my answer key. Very nicely done, dear. Okay. In the beginning only you completed all the questions, but if it is not the thing, initial management, till how you are supposed to say about initial management? Because I asked you regarding initial management.
CRM, CRMA.
So what A means, up to what? Because you ended
Call
with
for help. Call
hysterectomy.
for help and resuscitation.
Yeah, stabilization and stabilization. Okay, so that is call for help and stabilization of the patient, and max to max starting her on
IV.
means, yeah, IV fluid. No, max to max starting her on oxytocin drip.
Mm.
Okay, till that only the initial management comes up. Always remember
Okay.
that. Okay, and then if you think you are not, means you wait, you assess the situation whether there are any question from the examiner for you, then only jump onto the medical line of management and surgical line of management. Okay, one more point what I had mentioned here, introduce to the patient and midwife. Okay, because introduction with colleague and patient domain. Here CRMA needs to be activated. Meanwhile, details of hemodynamic status can be asked from the midwife. If unstable, then only you will be going ahead with the call for help approach. Okay, CRMA approach. So we had continued that only. Senior midwife, junior, senior trainee or consultant anesthetist testify on call. You missed out on anesthetist. Okay. Alert hematologist, alert theater, alert blood bank and laboratory. Okay. Blood pathology lab. Consultant obstetrician on call needs to be alerted or informed immediately. Commence on resuscitation without wasting any time. Airway, breathing, circulation, oxygen by 15 mask, 15 liter per minute, 100%. Two wide bore IV line. Uh, Collect baseline blood investigation followed by fluid. Okay. Followed by fluid infusion, IV fluid infusion, crystalloid followed by colloid. Till blood and blood products will be available. If not, then O negative or ORH negative or K negative blood can be transfused till blood group specific blood will be available. Cross match. Okay, coagulation profile. You mentioned here. I didn't listen to that point. I had mentioned
Yes,
here.
ma'am. I
You
mentioned that.
mentioned. Okay.
Only I
So,
fluid I
yeah.
missed.
Yeah, fluid though I mentioned, even coagulation I was not able to listen because that flow was very fast. Cross match 4 units of red blood cells. Keep blood and blood products ready here. FFP, platelet, precipitate. Now monitoring and assessment. Keep patient warm. Uh, Investigation needs to be traced out urgently. Okay, we need to assess we need to know the patient's condition. So baseline blood investigation needs to be informed urgently. Here a porter can be involved for the same reason. Pulse oximetry, commence ECG, continue MEOS chart, assess for CVP line. If possible, CVP line can be considered in the early intervention only. Foley's catheter, introduction to root check, to mention about input and output charting. And start this patient on medical line of management. Here my first question ends. Okay. Then my next question. Okay. So now the initial resuscitative steps are completed. What will be the management of PPH? Take me through the various steps. So the first will be medical line of management, followed by second surgical line of management if patient failed to respond. Assess the cause. My first question point here is assess the cause for PPH. Would like to rule out 4 T's. Okay. And management will be accordingly. Here I would like to take few details regarding MOD, especially OVD, as OVD means because operative vaginal delivery is associated with traumatic delivery. Okay. Traumatic PPH. Any other risk factor would like to know. Okay. Any medical comorbidities, any coagulation disorder the patient is having, any bleeding tendencies the patient is having. So all those points I will be keeping in mind. Most of the time it is atonic, and if it is atonic, then medical line of management will be started immediately. uh, Stepwise approach. If no response, then surgery. Under all aseptic precaution, rub uterine fundus, ensure bladder empty. This is the sentence what you have to say there. Okay. Not only rubbing uterine fundus. uh, Meanwhile, you can ask your colleague or your midwife to start this patient on slow 5 unit oxytocin IV, and IV infusion of oxytocin. That will be 40 unit into 500 ml of isotonic crystalloid saline and run at the rate of 125 ml per hour. Yes, dear Dr. Sujan, you wanted to say something?
Yes, doctor, please. Need to tell. Hello?
Yes, yes.
Okay.
Yes.
Need to tell about every step. Who will do this step? So while
Yes.
I am
Yes.
making run
Yes.
for you,
Yes.
the
Yes.
anesthesia, make
Yeah.
the
Yeah.
oh,
Yeah.
okay.
Every time. Yeah. So this is actually, you are not going to do. This is actually a patient safety also, that you are going to delegate this work to the person. You are going to delegate your task or your work to the person, that is communication with colleague. You are going to do a uterine massage. Okay. You are going to do a uterine massage. Meanwhile, you are going to ask your midwife or your trainee or your junior to start her on IV infusion and give her, even anesthetist colleague also. If no response, then the next will be ergometrin, that is 0.5 milligram IV slow, or a carboprost 250 microgram every 15 minutes. Total 8 doses within 2 hours. But if there will not be any response after third dose, you need to inform your consultant, you need to inform theater. Chances of requiring surgical exploration will be very high after third dose of carboprostol. Meanwhile, to see or to have a continuity effect of tonicity, you can consider misoprostol per rectal or sublingual also, and tranexamic acid. Assess response. Okay, so once we had started this, do not stop there. Assess response to the treatment and assess hemodynamic condition of this patient. Okay, ask your ST5 friend to continuously monitor and assess the hemodynamic status. If patient responded, continue the same. If not, then what? Then it is examination under anesthesia and surgical option. Examination under anesthesia. So the patient will be, this will be discussed now, come up. Okay, now the second question, third question is medical methods failed. What will be your next line of management? So if no response, then uh, patient will be
Surgical.
shifted to theater. Here, obtain consent if uterus is not contracting for examination under anesthesia, repair any tissue trauma, and if needed for surgical procedure also, we need to take a consent. WHO safety checklist will be the first thing. Antibiotics, assess risk of VTE. Here the patient is bleeding, so it will be mechanical thromboprophylaxis, adequate hydration, maintaining hypothermia. Okay, because we have to maintain that hypothermic state. These are the points with which you are going to mention minimizes the risk of thromboembolism. If possible, coagulation profile can be means asked. Means here we can ask for a coagulation profile, and if there are massive hemorrhage, then correction needs to be started as early as possible. So for every blood transfusion, okay, for blood transfusion, there will be 4 FFPs and 2 cryoprecipitate if fibrinogen levels are abnormal. Okay, yes or no? 4 or
Yes.
6? Somewhere it
And
is mentioned 4, somewhere it is mentioned 6. So you can mention 4, you can mention 6. But if there are, and the protocols for massive hemorrhage, okay, massive obstetric hemorrhage needs to be activated, and the patients will be transfused depending upon that. Here you, another important point, you are not going to go this procedure on your own. The procedure will be always done under supervision or by consultant. Okay, always need senior obstetrician needs to be there. If surge first line management for first surgical line of management for PPH, atonic PPH will be Bakri balloon or balloon tamponade. Under all aseptic precautions, we are going to go ahead with that. If not responding, then go ahead with the next level of next stage or next step, that is either a Bakri breast sutures, which you can explain. They might have a model for breast suturing, and they might ask you how you are going to do this, demonstrate me. Or the next will be stepwise devascularization. So you mentioned unilateral followed by bilateral, and if not, then go for internal iliac artery ligation, unilateral, bilateral. Okay, if facilities available, then uterine artery embolization is important. Okay, it is very important. And the last resort, if the patient continues to bleed and there is no chances of responding to medical and surgical line of management, then the last resort will be hysterectomy. The decision will be always taken in the best interest of the patient by two consultant. Okay, this is the next point, next thing. Now coming to the post surgical management, you had mentioned here, I really impressed. Only point which you had missed out was baby point. So that's the reason I asked you regarding the baby point. You mentioned most of the points very nicely, dear. Okay, so this question I'm very happy. And this last blood investigation they had given, so yes, patient will be require a blood transfusion, activate a massive hemorrhagic protocol if blood loss is more than 1 liter. Transfuse packed cells. Okay, FFP 12 to 15 ml per kg. Cryo 2.2 units of 5 pool to maintain fibrinogen 1.5 gram per liter. What I had read today only, it is the aim will be 2 gram or 1.5. I do not remember actually, but somewhere I read about 1.5. Our
1.5
aim,
here.
Yeah, our aim will be that, but our aim should be that.
Aim is 2 gram postpartum fibrinogen
2
level.
gram postpartum 2 gram, I guess. That GTG it is given 2 gram.
Oh, PPH GTG has given that. I read today regarding that blood transfusion GTG.
Okay,
Yes.
okay, ma'am. Okay.
Okay, so actually, two miss somewhere it is mentioned. They had mentioned 6 point for every 6 point of blood transfusion, 4 points of
4
FFP.
units.
Yeah, and I think PPS guideline had mentioned that 4 points of blood transfusion, 4 points of FFP. So this is actually 1.5, and the recent whatever whichever guideline will be the recent, we will take from that. Okay, we will take it from that. APTT is normal. So, patient safety, when coming to the domain wise scoring, identify as an emergency, which you had identified, use of CRMA protocol, allergy, say prescription, understanding risk from intervention, IV oxytocin, fluid overload, carboprostol, asthmatic patients, okay, contraindication you mentioned, accurate prescription to stimulate uterine contraction, including management of intravenous fluid, understand risk management, clinical governance process in relation to massive PPH, fluid management including blood and blood component transfusion, which you had mentioned. Okay, you were safe doctor today. Knowledge regarding clinical knowledge, you were having perfect clinical knowledge. Communication with patient and their relatives, introduce self and role is very important. Able to communicate to the patient and partner regarding the interventions for PPH, including investigation and management steps. Consent here, because we are taking this patient for the theater, consent is another way of communication with patient and their relatives. Communicating clearly, appropriately, management plans, appropriate intervals, and debriefing. Post procedure debriefing is also communication. Information gathering, whatever information has been given to you, and okay, that is one point. And other point will be you are going to ask, access the notes, MOD, okay, operative journal delivery, labor details. You are going to take that, and you are going to ask for these four T's. Okay, in the answer key, they had not mentioned, you must have noticed that the answer key they had not mentioned about 4Ts, but in the information gathering they had mentioned about 4Ts. So somewhere somehow whenever PPH comes up, you have to bring out these 4Ts very appropriately, so that you know what kind of PPH you are means you are means what is the cause of PPH, and your management will be according to that. Initiate appropriate investigation which you had initiated, and appropriate management also which you had done it. Okay, communication with colleague, appropriate way of communicating with colleague, because you were very logical, sequential, delegate, ability to delegate task appropriately, very nicely pointed out by Dr. Sujlan. Okay, that you have to delegate your task. You are not so going to say that I will be doing, I will be doing, I will be doing, because most of the students who are there in the emergency situation, they keep on saying I will be doing this, I will be doing this, I will be doing this. The moment you will be saying I will be, I will be, you will be failed in the task, you will be failed in the task. You have to delegate tasks to the respective people. Okay, so monitoring and IV fluid, you can assign that task to your ST5. Blood collection, blood transfusion, you can assign blood collection, and IV fluid, blood collection can be very easily assigned to the midwife, and the porter can take away the sampling. Few catheterization can be done by the junior trainee or a midwife also. Okay, so you have to delegate the task appropriately to the people. Understand limit when you need to involve your when you need to involve your consultant and other specialist. Okay, and involvement of anesthetist, blood bank, and junior colleague. Junior colleague is very important here. You just inform the consultant. One more point here, you inform only consultant and midwife. Okay, you, and then rest of the people, anesthetist you didn't inform, and junior colleagues also you didn't inform. Ability to form a logical differential diagnosis for causes of PPH, to able to convey to the colleague on and off site. Communicating appropriately, succinctly the management plans at appropriate intervals with colleague. Documenting her care and SBAT. Okay. Asma, Asma, you are late today. Okay, so I will stop the recording.
Yeah,
Uh,
Doctor, I have one question, please.